Hello everyone. Good morning. I'm Dr. Hitesham, going to present approach to isolated raised ALP. It's a clear exam-oriented clinical approach to isolated raised ALP. That means normal ALT, AST and bilirubin. Only ALP is raised. The first step is to confirm the elevation. For this reason, we will have to repeat ALP level 1 to 2 weeks later. Check if there is any lab error or post-meal variability. We know that ALP rise after meal. Step 2. Identify the source of ALP. We know that ALP mainly comes from liver, bones, placenta and intestine. So, where is the source? Is it liver? Is it bone, placenta or intestine? It is the key step. For this reason, we can order gamma glutamyl transferase, that is GGT. If GGT is raised, then it is hepatobiliary source. If GGT is normal, that means it comes from bone or other sources. If hepatic sources is identified, that means raised gamma glutamyl transferase, then it may be due to cholestasis. Cholestasis are two types, that may be extrahepatic or intrahepatic. Gallstone, common bile duct stricture or pancreatic mass can cause extrahepatic cholestasis. And in case of intrahepatic cholestasis, it may be PSC, PBC and some drugs, that is oral contraceptive pill, anti-epileptic drug can cause cholestasis. Number 2, infiltrative disease, that is TB, sarcoidosis, lymphoma and metastasis. Number 3, congestive hepatopathy. What are the investigations if it is hepatic cause? We should have to measure other liver function tests, that is ALT, AST and bilirubin, ultrasonography of hepatobiliary system, autoantibody, that is AMA, ANA, IgM and lastly MRCP. And consider liver biopsy if we suspect it's a case of infiltrative disease. So, if GGT is rise, that means it's a hepatic cause. In case of hepatic cause, we should have to exclude is there any cholestasis or any infiltrative disease. Cholestasis are two types, extrahepatic and intrahepatic. We will have to exclude both extrahepatic and intrahepatic cholestasis by other liver function test, ultrasonography and autoimmunoprofile. Step 4. If GGT is normal, then what are the causes? It may be bone source, high bone turnover. We know that in case of Paget disease, vitamin D deficiency, hyperparathyroidism, bone metastasis and healing fracture. In these cases, there is high bone turnover. So, we will have to investigate serum calcium, serum phosphate, parathyroid level, vitamin D and X-ray or bone scan if needed. There are some physiological causes, as ALP also comes from placenta. So during pregnancy, it raises, adolescent raises and postprandial rise if in case of blood group B and O. If patient has blood group B or blood group O, then postprandial rise is common. What are the red flag signs? If ALP rise more than 3 times of the upper limit, if persistent elevation more than 6 months, if there is symptoms, that is jaundice, pruritus, weight loss and bone pain. So, what are the summary? Isolated raised ALP, you will have to repeat it, and then if confirmed raised of ALP, then check GGT. If GGT is raised, it is liver origin, then you will have to do ultrasonography. If no disease is found or if suggested, then AMA and MRCP. If GGT is normal, most likely it is bone origin, then you will have to do vitamin D, calcium and phosphate. So in summary, take home messages are: isolated raised ALP is the most commonly seen either cholestasis or bone turnover. সো যদি কখনো আইসোলেটেড এএলপি বেশি আসে, আমরা দুইটা জিনিস চিন্তা করব, আইদার কোলেস্টেসিস অথবা বোন টার্নওভার। এই দুইটাকে আলাদা করার জন্য বলছে জিজিটি ইজ দ্য সিঙ্গেল মোস্ট ইম্পর্টেন্ট ডিসক্রিমিনেটর। জিজিটি দিয়েই আমরা দুইটা থেকে একটা থেকে আর একটা ডিসক্রিমিনেট করতে পারবো। থ্যাংক ইউ অল। দিস